Good morning, everyone. Welcome to this webinar hosted by the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, and the Pan American Health Organization, PAHO. Today's topic is men's health, gender-based violence, and COVID-19. I am Dr. Rosman Adams, the director of PANCAP, and I will be facilitating today's webinar. A few housekeeping matters. Your mics are all muted. Please type and submit questions in the question field, and we will address these questions after the two presentations today. We are also recording the webinar and will share the recordings on the PANCAP website and social media platforms for the benefit of persons who could not have attended this live session. We will also be administering a few polls during today's session, and we ask that you participate in these polls as they will help to provide feedback for future webinars and also to gauge the presenters and the discussions that we will be having today. Participants will receive a post-webinar evaluation and also a certificate of participation. We ask that when you receive this post-webinar evaluation, please complete it. Please complete your feedback. Please complete it, and because your feedback is very important for us as we seek to improve and develop on these webinars. We have two speakers this morning. Our first speaker is Dr. Peter Douglas Weller, PhD in community and clinical psychologist. Dr. Weller is a Jamaican who attended the University of the West Indies, Jamaica, and Howard University in Washington, D.C. He completed his master's and PhD degrees in clinical psychology at Emory University in Atlanta, specializing in community clinical psychology. He served as a research psychologist at the U.S. Centers for Disease Control, CDC, and the first psychologist for the AIDS program at the Ministry of Health, Jamaica. Dr. Weller is a member of the past president of the Jamaica Psychological Society and a member of the Trinidad and Tobago Psychologists Association. He sits on the Council of Presidents and Elders of the Caribbean Alliance of National Psychological Associations, CANPA, from which he received the award, the Forerunner Award. He co-chairs CANPA's working group on disaster, mental health, and psychological support, currently focusing on the novel COVID-19 and hurricane season response. Dr. Weller is the founder of and former chairman of the Caribbean Male Action Network, CARIMAN, and served as an advisor to the gender specialist at CARICOM, and currently sits on the board of the Coalition Against Domestic Violence for Trinidad and Tobago. His current focus is on adult psychotherapy, group psychoeducation, and community interventions for social change. Dr. Weller brings to this session 30 years of experience as a clinical psychologist. Welcome, Dr. Weller, and I'm going to turn over to you for your presentation.
Thank you very much. Good morning. I'm going to activate my presentation now. There's a little challenge here, but morning, everybody. It's a pleasure and, of course, an honor to be invited to be a part of this forum. I'm trying to get my screen activated here. Nothing is happening. I may need some assistance from my colleagues at PANCAP if they're able to load the presentations from that end. Okay. So while we wait for the presentation to load, Coming from my experience as a psychologist, I have to tell you that my bias, so to speak, in doing this work is always from the perspective of behavior change and what are we trying to achieve. So we're talking about men and health and some of the considerations we need to have as we try to manage during this COVID-19 pandemic. Next. It's really critical that we understand that this is about shifting paradigms and perspectives. If we're going to respond to the challenges that COVID-19 presents while still coping with everything else that has gone before, we're going to have to shift our paradigms and perspectives. And I usually start my presentations with these two images. So you may have seen them before. Many of you would know them perhaps from your training. The image on the right is a little more abstract, and people usually see two images within that picture. Our participants hopefully will take a few seconds and look at it and decide what they see. Whereas the image on the right provides a different kind of perspective. So on the left, we have two images. Usually people see an older woman and some see a younger woman, but they're alternating perspectives. We don't usually see both of them at the same time. That's not how the mind works in this context. Whereas the image on the right shows a man, and you see him alternating very quickly between looking to our right and looking towards us. And I use this image to highlight the importance that our brain is structured in such a way to process information. You know, we develop paradigms, we develop automatic processes for seeing things. And when we talk about changing behavior, we have to understand that it can sometimes be a complex process, but there are ways to achieve it if we are careful and if we get the right information. Changing the behavior of men is not just about changing the men themselves, but it is changing the systems that influence the men, including those of us who are providers, who are healthcare practitioners, who may have our own paradigms and perspectives and perhaps even biases that influence how we work with men. The brain having been structured to really for safety and security and survival, it is very strongly and deeply programmed in that way. And whereas nature and nurture interact to help us to modify and perhaps change the way we think and feel, those deep programs, those early experiences, those genetic temperamental dynamics can make certain attitudes and beliefs very difficult to change. But we know of neuroplasticity, we know that the brain can change. So we need to know how to work with individuals in order to facilitate that process. We're talking about reprogramming here. We're talking about trying to change the way people's minds work, in particular men. But again, we as a healthcare providers also have to change the way we think. So next slide. When we start talking about masculinity and men and men's issues, very often we get into a kind of mindset that looks at competing victimhoods and power grabs. And it is unfortunate because sometimes it's just a matter of having different perspectives and different priorities. The image on the left highlights how we are actually programmed to look at hierarchy and power and structure. With the ego, the kind of identity of the individual or the organization that is most powerful, always put at the top of the pyramid. And unfortunately, that then leads to certain systemic structures and ways of thinking that are very automatic and also are not equitable and not fair. Some would prefer to look at nature as it is on the right and think about the fact that we are all interconnected and that what happens to one person is going to affect the others, with no one person having priority. However, there are always different perspectives. So when we talk about working with men, we're part of a process of socialization. Can I have the next slide, please? That has affected not only the men who we're trying to influence, but all of us. We are talking here now in the context of health and the health issues that we know are likely to affect everybody. I certainly don't need to tell a team like this about the issues of hypertension and diabetes, the mental health issues of depression and anxiety, some of the addictive behaviors and eating behaviors, etc. All of these are health issues. But when we start talking about men's health, we sometimes start to get very focused on certain issues. The next slide. And as Dr. Etienne has said, when we compare men with women, men have a mortality rate 4 times greater due to external causes and a 7 times greater risk of dying from homicide. So there are unique differences between men and women, and particular challenges that men face. And to focus on them is not about prioritizing men over women. It's not about supporting patriarchy, although some people feel very uncomfortable when resources are put towards working with men. And that is understandable. We need to have an equitable allocation of resources. But there are issues that need to be addressed, and we have to look at and be careful that our paradigms, especially when we are looking at rights-based initiatives and healthcare disparities, our paradigms don't limit how we look at the concerns that men have. So next slide. So yes, we're very accustomed to looking at men's health behavior and thinking about things like alcohol and substance abuse, recreational drugs, sexuality, risk-taking behaviors such as driving, violent sports, the fact that men are more likely in the workplace to be injured because of the kinds of jobs that they have, criminal activity and homicide, suicide, and of course, the preventable diseases, all those chronic and non-communicable diseases that are a function of lifestyles. But we have to be very careful that we're integrating that with all the concerns that we have about men with hypertension and diabetes and cancers, etc. What do all of these things have in common? Well, what they have in common is that they are affecting the health and wellness of everybody, including men. But men have a certain socialization and perspective that influences the behaviors that put them at risk and the behaviors that might help heal them and take them into wellness. Next slide. So another paradigm that we have to really examine is that some of us, not all, but some of us think of health and wellness very much in terms of the physical. But I would like to just remind us that there are many dimensions. Our wellness includes our social and interpersonal relationships, our intellectual and cognitive functioning and the stimulation that we need, our spiritual dimension, which operates in different ways for different people, our emotional health and mental health would fall into that category, and of course our occupational wellness. They're all connected, and so any interventions that are intended to promote wellness in the society and particularly among men must include a conceptual frame that integrates all of these dimensions. And this is one of the challenges we face because we sometimes are very linear and very narrow in our focus, as if someone's decision, for example, a man's decision about his behavior, is going to be about and based on physical needs, etc. Well, we know that many men choose to behave the way they do because of dynamics that are integrated from all these dimensions of wellness. And we as healthcare providers need to be prepared to integrate them in our conceptual frame, our diagnostic strategies, and our prescriptive or interventions as we go forward. Next. So as I highlight some of these issues, I mean, we only have 15 or 20 minutes, and I just want to put some concepts and contexts on the table, so to speak, so we can consider them as we focus on COVID-19 and men. And that is going to be in the second part of our presentation next week, Friday. As it is now, I just wanted to highlight that, there's a fairly well-known quote that John F. Kennedy used talking about a crisis is a time of danger and opportunity. Turns out that that is actually taken from a Chinese saying, which really focuses more on the issue of choice, that in a time of crisis, of danger and opportunity, we have an opportunity to make new choices, to make different choices, and to perhaps make changes that can have effects that are bigger, greater, longer, and more important than the crisis itself. So, next. I think that therefore we have to really examine our paradigms when we talk about how we're going to work with men to improve their health behavior, and those of us who are men, how we're going to improve our own behavior and be positive peer models, how we're going to talk to men as women who are care providers or are as partners and community members. We have to look at where we're coming from. And of course, very often in our discussions about COVID-19, we talk about the pre-existing conditions. So we focus on the health dynamics, the hypertension and the diabetes, etc., and the neurological dynamics that can put people at greater risk. But I want to talk about a different kind of pre-existing condition. I'm talking about how we think about masculinity and how we think about working with men. Because there's a danger sometimes that, as I said earlier, we pathologize and problematize the man as somebody who is causing problems or misbehaving because he won't do the right things. And we have difficulties prioritizing our focus because it looks like we're privileging when in fact, actually what we're just doing is ensuring that we have a positive profile and that we can engage in some psychologizing, so to speak, as in a behavioral understanding that informs our intervention. So we have to shift and be careful how our programming influences our choices, both at the macro level of policies and programs and at the practice level in our individual interventions. But we're also working in a society with a socialization that has taught men and taught us all traditionally and conservatively to see men and masculinity as about being powerful, as about being a protector, being pro-risk, being a provider, being a procreator, and being a problem solver. That very often is the context in which men are measured, and that men measure themselves in terms of their ego and their identity and their gender roles. And this is not only a perception of men, it's a perception of some women too. It's not all men. But what we really have to keep in mind is that if we're going to be intervening, if we're going to be having effective change processes with regard to health, we have to understand the mindset of our target audience. Now, this is something that is well researched. It is how social media, this is how marketing is informed, and it's how social marketing has been used, for example, in HIV to great success. The question is, as time has passed, how are these dynamics changing? Not all men buy into this. And it is a challenge when we make assumptions that all men have these traditional and conservative views. That is not necessarily the case. We need to look beyond it and ensure that when we are designing our interventions, whether it's a face-to-face interaction or it is a program, we understand how men have been socialized and we make the appropriate choices as to how to engage with them. Next. So we have opportunities for change. Unfortunately, because of that programming that so many men have, health-seeking behavior is seen as help-seeking behavior, which is then seen as a weakness or a vulnerability, and it is not manly. We have to find ways to change that programming of the mind by changing our programming as healthcare providers and social change facilitators to ensure that help-seeking is seen as a way of building strength, of future strength, and therefore help-seeking and health-seeking behavior are positive and are a sign of healthy manhood. And to do that, we really are going to have to understand the changing dynamics of masculinity and manhood in the world as it goes now. Gender is being redefined. There's far more diversity among men, a lot of masculinities, as it is said, and a lot of intersectionalities. And therefore, the men who may be seen to have power may be also part of a different set of people who don't have power, whether it is based on race or religion, whether it is socioeconomic, whether it is sexuality. all of these factors are going to influence how men operate, the choices they make, and they're going to influence how we have to engage with them as we go along. Next. So here we have a man, and I just use this image because I find it very interesting. Here's a man, probably a father, but certainly a caretaker. He is taking care of a young boy, maybe his son, while he's riding on his bicycle, while he's talking on his phone. Now, at first glance, people have looked at this picture and said, well, there you go. Obviously, very masculine, macho, risk-taking, multitasking, but yet he's also caretaking. And I think that we have to be very careful that we understand that this might be an example of multiple programs running in the mind of this man. He has many tasks, he has many roles, there are many expectations, but he has to learn how to make the right choices to ensure that his behavior is safe. In this context, he has actually stopped, and if you look carefully, he has his foot on the ground, so he's not actually moving. But the little boy on his head is really not in a safe position. He may have no other choice but to carry him in that way. But what we are trying to do is to ensure that we understand these multiple factors influencing men so that we can intervene appropriately. Next. And some of the things that we need to consider in terms of managing our interventions include policy approaches. So we need to use rights-based, and it's not whose rights are more important than who else's. We need to ensure that our policies and programs enhance the lives of men and boys, that they're affirmative, they're not punitive, they're not seeing men as the problem, and are sensitive to the diversities and the intersectionalities. Men are different, they operate and think differently, and we need to acknowledge that and understand it. I mean, the work with HIV has certainly taught us a lot of that. About the need for this kind of appreciation of the diversity. We need to ensure that quality health services are available and that in those services, the access is facilitated. We need to facilitate demand for care, so there needs to be programs to ensure that men understand why they need care and why they need to seek it. But we need to avoid negative gender exploitative messages, and I mean those that try to get men to do the right thing, but for the wrong reason. And that is why when earlier I said that we want men to see seeking help as a strength, we want to ensure that it is seen as a strength over self, but not reinforce this issue of strength over others as a macho quality of masculinity. Because all of this is taking place in the context of our social and economic and political factors. And that is a way of understanding how we can build benefits and incentives and cost and consequences. You have to know what is important, what will motivate and mobilize men, including what other men think of them. So there are policy implications, and next. There's the programming. Now I'm just going to highlight this one part because I think it's really important to understand that if you're working with men, or women, whatever work you're doing, there needs to be an appropriate gender analysis that looks at the different roles and statuses and ways that people are affected by your program. What are their needs and what is going to happen when they intervene? And we need to move away from what I call gender exploitative types of reasonings into more gender transformative, with the gender exploitative end being the kind of message that perhaps some of you may be familiar with Stag Bears, and they used to do a lot of advertising about it's a man's world, rule it responsibly. So yes, they're telling people to drink and rule responsibly, but they're also exploiting that patriarchal macho dimension of men as having to be in control and in charge. We want to move away from that kind of messaging, and it's really important that in our programming, whether it is at the organizational or even just at the individual provider level, we're using messaging that is healthy and transformative and not exploitative. Next. So we want to work with men as part of the solution, not just the problem. We have to meet men where they are. And so in the work that we're doing, we have to understand where men are, both in terms of their mindsets, but also in terms of the interventions, workplace-based interventions, outreach that is done with athletic clubs and in social settings, are all important mechanisms for getting the message across, especially, as I said, in the socio-political, cultural context. A holistic, multi-pronged approach. We have to ensure that media messages, social media, faith-based organizations, etc., all in the same place. And one of the big challenges there is that, of course, some of the messaging, while it may be in sync in terms of intended output, is not in sync when it comes to the rationale, etc., that is given for the behavior. So this is something that requires a lot of work. We need to train our service providers to become more gender sensitive. We're all part of the same society, and the same biases and prejudices and cognitive dissonances exist in our minds. So we have to be very vigilant that these programs don't send unintended messages and that they're not potentially leading to more harm, both for men to themselves by increasing the need, for example, to be more macho and take risks, or in terms of their interactions with women in terms of abusive or violent behavior. The next one. So let us make those choices as healthcare providers so that men will make the best choices. We know that men are diverse. We know that they have both desirable and undesirable attributes. We need to continue doing the research and develop the targeted interventions that will help men to understand and be accountable for their behaviors in all aspects of their wellness. Then they're going to be more likely to change. So we have to work strategically and with the partners, with our faith-based organizations or CBOs and NGOs, the organizations that we know will influence men. And we need to understand what kinds of messages need to be developed and be carried by these different stakeholders. You know, we have the big Spotlight initiative in the region that is providing some funding. We have specific issues coming up with mental health and psychosocial services around the pandemic. But the bottom line is that we need to collaborate and coordinate. One of the reasons why people don't change their behavior, and in this context it's men, is that not only are they not getting the right messages, but they're getting conflicted messages that override each other. We want to try to facilitate safe behaviors in terms of health. When we talk about COVID in more detail, we're going to focus on the behaviors around safe surfaces, safe mindsets, safe relationships. Next. And before we get to that, and before I end, I want to just emphasize that this pandemic, this COVID pandemic, is particularly challenging for each of us and all of us. But there are challenges that men face because of the gender socialization and because of their own expectations. And we certainly hope that, as we discuss next week, some of the dynamics that are affecting men, we'll be able to leverage them and look towards their implications for health behavior, both physical health and mental health, but also in terms of those safe relationships. How are men being affected in terms of that, their dynamics with women, with children, and with those who are more vulnerable? We'll be picking up on that and discussing that next week in the next seminar. Thank you for your attention.
Thank you very much, Dr. Weller, for that very comprehensive presentation. Looking at wellness is more than just physical health, and looking at the social and mental health dimensions and the opportunities that the current pandemic COVID-19 can present to us in order for us to look and tackle a number of issues related to men and men's health. Also, you looked at the opportunities for change and mentioned that we need to look at how men can be part of the solution, but not just the problem. When we look at the most recent UNAIDS report for the Caribbean region, 57% of the new infections are among men. And I think that right away, when we look at this, what we see is a problem. However, I like in your presentation that you mentioned that we need to look at it as a solution. How can we look at this and start looking for ways of reaching men in order to decrease the incidence and these new infections in the region? And this is a two-part series. And so next week, you're going to focus more on COVID-19. and the role that men will play in terms of reducing the spread and tackling other issues related to that. So I thank you very much for that very comprehensive presentation. We're going to move into our second presenter. But before I do so, just a reminder that we are conducting some polls along the way, and so please participate and provide feedback to those. Our second presenter this morning is Mr. Hanif Benjamin, who is a Trinidadian. He gained his Bachelor of Science in Criminal Justice at Monroe College and his Clinical Master of Social Work from Fordham University in New York. He developed specialized skills in trauma treatment for children and adolescents whilst there, and he's a certified trainer of trainers in New York State, having completed the Advancing Youth Development Revised Trainer or Facilitator program for Cornell University. Mr. Benjamin is a licensed Master of Social Work by the New York State Office of the Professions and a member of the American Academy of Experts in Traumatic Stress and the National Center for Crisis Management. He is a clinical traumatologist and clinical therapist. Mr. Benjamin received many accolades from his work in New York, namely the Essa Abed Award for Distinguished Contribution in the Promoting of Cultural Awareness, Social Justice, and Coalition Building. He received the Catholic Interracial Council of New York Award and is an alumni of distinction from the Monroe College. Welcome, Mr. Benjamin.
Thank you so much, Doctor. Thank you for having me. A pleasant good morning to all viewing, listening throughout the world. It is indeed a pleasure to journey with you yet again for what I consider to be timely and important conversation as it relates to gender-based violence and men's health. Dr. Peter Weller laid a very lovely foundation as he spoke to men and the importance of paying attention to men's health. And that by no means makes women's health insignificant, but rather to pay particular attention as both genders has its unique health challenges, both mental and physical. And so this morning, I want to walk you through really understanding the beginning. Because while it is important to understand the end result, much as what Peter has spoken about, it is important for us to understand the beginning phases of this. And I want to start by how childhood trauma affect health across a lifetime. Because between this week and next week, we will journey as it relates to men's health. But specifically for me, I want to focus on trauma and childhood, more so trauma, childhood, and boys, because some of what Peter spoke about has its roots in early development. And Dr. Nadine Burke, pediatrician, she explains that repeated stress of abuse, neglect, parents struggling with mental health, substance abuse, and other types of issues has a real effect on the development of the brain. And as we know, a child's brain is ever developing, it's malleable, it's changing every day. And it is changing based on what it is given. And so that whole social environment, the ecological model that Yuri Bronfenbrenner spoke about, that really solidify who a child is and what they grow to become. And so I always say to people, when we grow a tomato tree, we spend an inordinate amount of time pruning, sharing, putting the stick, moving. It leans to the right, so you help it to lean back to the left. It leans too much to the left, you cover it from the sun. That is what the ecological model speaks about in relation to how we help a child develop over time. And so what Nadine Burke has said to us here is that a constant and pervasive level of stress on a child may lead to issues as they grow into an adult. So what we invest in children now will be the benefit or lack thereof for what we get when they turn into an adult. And sometimes we tend to forget that these children, bruised and battered, grow up to be adults. And whether or not we are paying sufficient attention to what type of adult they turn into. And so I follow the work of Jeffrey Canada from Harlem Children's Zone in New York, who went on to do great things there. And in his book, Reaching Up for Manhood, it really helps us to zone in on a look at the little understood emotional lives of boys. Why is that? A lot of what he spoke about resonates within the Caribbean diaspora. In that, what have we learned as boys growing up? I know I have sisters, but I know that my sister cannot be outside after a particular time, but yet we can. We know that boys have little to no supervision, especially when they're getting into adolescent age. We know that boys and their health, their physical health, seem to always take a back seat. We know these things to be facts. We know that boys, because of its nature and curiosity, they get into more trouble. They are more risk takers, even though adolescent lives are generally risk takers. But we know that boys are more risk takers. But we also know, ladies and gentlemen, that we take little time to understand their emotional lives, in so much as we tend to tell them how and when they should be emotional. As a matter of fact, Jeffrey Canada, when he spoke about the box, the man box that we put our boys into, where society has said or is saying to them that, hey, this is who you must be. This is what you must become. And there is no room for movement. And so we have prescribed a type of life for boys, a life that really is pushing their true emotions aside. So from very early, we have taught our boys that they should not be emotional because that is for girls. We have taught our boys that they should be hard, rough, and tumble because that is what boys do. And if you show any sign that you might be emotional or show emotion, you would have been chastised to the harshest of words, and in some cases beaten by your peers sometimes because what they were told, by fathers in particular, because they don't want no boys like sissies and stuff like that, and or by their mothers as well. Get up, dust yourself off. What you crying for? Those are the words that resonate in the boy's life. And so for a big part of their development, their social environment that I spoke about, coined by Yuri, has said to us that, hey, these boys are to grow up in a particular way. These children are to move in a particular way. And so when you examine trauma and its impact on boys' health, both mental and physical, because I tell you, the way we grow our boys has a direct correlation to whom and what they become later on. And so if we were to pull out just a few, let's begin with attachment and relationship. Everyone knows, and we talk about Freud and Piaget and Erikson, everyone speaks to stages of development. And there is a stage where attachment is a critical critical part of development. And this, I mean, as it's saying here, we cannot overestimate the importance of that attachment and relationship that a boy needs with his parents. And so if a child is being abused, if a child is being neglected, because when you look at some of the data coming out of the Children's Authority of Trinidad and Tobago over the time that I've been there, the three main types of abuses that we would have faced there would have been sexual abuse, physical abuse, and neglect. And the question arises whether or not the first two is a direct correlation with the third, which is neglect. Because when our children are neglected, that means they're unsupervised. When they're unsupervised, they fall prey to evil eyes and hands. So the question for us is whether or not a level of neglect has caused a level of detachment or misattachment that goes on here. When those relationships are unstable or unpredictable, children learn that they cannot rely on others to help them. And therefore, what does that mean? It means then that children find ways to protect themselves. Now, I want you to bear in mind that a child's coping mechanism is very limited. That child coping mechanism is the sum total of what they see, what they read, and what they interpret to be so. And so they tend now to fend for themselves. Unfortunately, that fending for self can turn into what we call bad behavior. And what we would have seen, especially in the Caribbean region, is children, boys especially, being beaten by parents, being labeled by some of us professionals as well, because they took on a role to protect their own health, mental health status. And so when you look at physical health, body and brain, we know that throughout from infancy all the way up to adolescence, the body is developing, the brain is developing. Normal biological functioning is partly determined by the environment. And you would have heard me spoke earlier about the social environment, the ecological model again. And so when a child grows up in a dysfunctional environment, when a boy grows up in a dysfunctional environment, what happens to that child? That child becomes afraid under constant or extreme stress. The actual body, the immune system, the body stresses response system may not develop normally. And that is why when Dr. Nadine Berg at Kaiser decided to examine why children were sick all the time, and you examine their environment, you saw the level of toxicity that they were living in. Now, what happens later on? This same child, or when they become an adult, is exposed to an even ordinary level of stress. These systems may automatically respond as if the individual is under extreme stress. So some of the things that Peter spoke about are the very things that laid foundation in childhood, where these children would have gone through this level of stress, their body would have taken shape. Van der Kolk in his book, which deals with the body keeps the score, is a powerful book because it speaks about trauma that is continuous from childhood into adulthood and what that does to a person. So when they respond, we need to really examine whether their response is as a result of bad behavior or their response is one of survival. When we look at their emotional response, children who have experienced complex trauma often have difficulty identifying, expressing, managing emotion, and may have limited language for feeling state. So a child or adolescent may not be able to verbalize how they actually feel. And I'm wondering here, and maybe when we get to the question and answer period, maybe people can tell me, when you're working with young people and they start to curse, use profanity when they are angry, you ever ask yourself why that is? Because they, in their limited coping mechanism, cannot find the language to help them express how they feel. So they use these profanities to help them to design that. That is why when I work with young people, and some of you may not agree with me, but I say I really am not interested in the profanities that is being spoken at that time, because I know it is out of frustration. But sometimes we hold that against the child or children or adolescent, and therefore making it even harder for them to express themselves. What I will do after they have calmed down is help them to find the words to express their feeling, so they will not use the profanity in future circumstances. But that's a practical thing there. You see, they often internalize and or externalize stress reaction. And, you know, Dr. Burke used a best example. And the example is, if you are in a forest and you're being chased by a grizzly bear, obviously that part of the brain will kick in. Your amygdala is going to come, fight, flight, or freeze. You're going to start to run. Your heart is going to be pounding. You're going to be sweaty. Cortisol going to be pumping because you are trying to survive. And the good thing is you outran the bear, so your body normalizes. However, when a child is living in constant trauma, they are running from a bear every single day, every hour for their life. And so all through their childhood, they are running from this bear. So you can imagine your body on hypervigilant, or what in local Palang we call jumpy. So you can imagine you are living in a state of anxiety every single day as a child. That is helping you to develop a platform for the type of adult you will turn into. So for a child with complex trauma history, reminders of various traumatic events may be everywhere in the environment. And I always look at the five senses. Something you smell may remind you of an abuse. Something you see, something you hear. And so the environment in which this child grows up in can very well be their downfall as an adult, and therefore will set up how they see the world as they grow into adulthood. When you look at behavior, and this is a major one, because we are very punitive in our response to children. And that is why I could never support corporal punishment, because a child may be responding to a stimuli or stimulus in the environment. They may be trying to protect itself from what they perceive as that bear or that threat, and they may respond to that. But we on the outside may see this as a child who is bad behaved, who is a delinquent, who requires punishment. And so we have to understand a child's behavior in the context of the environment in which they grew. You cannot move to discipline a child without first understanding the social environment, because their response can truly be from a trauma-informed place. And that is how the brain is choosing to survive. And if that child got no help to help them regulate their behavior, then what we will be doing is punishing a child for surviving. And so that child will interpret that to mean that I have no allies, I have no one to help me, and therefore I will help myself. And that is why you find young people, they gravitate towards gang culture. because the gang culture is going to say, I will protect you. That is why they get into this type of illicit drugs, alcohol type of relationship. You know, because they believe that they are the ones who are going to protect them. When or they can go to the extreme and say, listen, nobody cares about me. And so therefore, I will just do whatever I feel, however I feel. And so you have to understand the struggle to regulate behavior, the struggle that they go through to calm down, not because they don't want to, but because their brain is wired to protect itself. And they are operating from that premise. And so it is critical for us to understand the complexity of the trauma, the lens of which that child is living, and the behavior that follows. And so, ladies and gentlemen, the long-term consequences. Traumatic experience in childhood have been linked to increased medical conditions throughout the individual lives. And that is what some of the things that Dr. Peter Weller spoke about. But I will put this here before I leave, because on the next occasion, I want to show you the correlation between the adverse childhood experience, or the ACE study, and the long-term effect. So I want you to understand how the trauma affects that child, that boy, and how that boy turned into a man, and what type of man or manhood we are going to be seeing. And so it is very, very critical. And so if you understand the continuum from boyhood to manhood, especially one that is dealing with trauma, you will understand why as a man you have high risk smoking, unprotected sex, chronic illness such as heart disease, cancer, all of these things. And so I will go in depth into what the long-term effect is at our next sitting. And so at this point, I want to, well, I know we're going to go into question and comments. So I want to thank you for being a lovely and attentive audience, and I will take it over, hand it over back to the presenter.
Thank you very much, Mr. Benjamin, for that excellent presentation, highlighting the unique challenges that men are faced with. But I also like that, you know, your presentation looked at re-understanding the beginning, because this is so important as we look at behavior change models. I think that we must understand the past and any interventions that we seek to put in place to address men's health and men's issues. Many times we tend to look at the present and we become frustrated because we do not see the impact that we're looking for. And I think that it is because we oftentimes do not go back to the beginning and to look at the past and to see how the past would have influenced current behavior. So I think that your presentation really highlighted the importance of looking at the past and re-understanding this, so that it can help us to put strategies in place to address issues related to men's health and other aspects related to men. I'm going to remind you that you can type your questions in the question box, and we will now look at them and pose them to our presenters. We have quite a number of questions that are coming in. One of the first questions that we have is related to what I think Dr. Weller would have mentioned, that we really need to meet men where they are. So the question is that where are men now, and what we have to do in order to reach out to them and to meet them where they are. Dr. Weller, both of you can take this question.
Good afternoon again, or it's still just about afternoon. But it's a big issue, and I think that what I tried to touch on in the brief time was that when we say we want to meet men where they are, We're talking both at the level of what are their attitudes and beliefs, what are their lived experience and challenges, and what are the actual spaces and places that we can intervene. You know, with HIV, we learned about working with men at the clubs. We learned about working with them at the various corners. We learned from research about attitudes towards sexuality and masculinity that were influencing risky behavior. We learned about the condom and its use and misuse and non-use. And we were able to develop initiatives at all those levels, both policy and program as well as practice. So I think that what we have to be working with now is an understanding that men are evolving. You know, there was a time when you would have never seen men with earrings. There's a time when you wouldn't have seen a father carrying a baby to the clinic. There are lots of things that are changing. So I think the first response is that we really have to continue to do the research, but not only do the research, but apply it. This is a pet peeve that I have, that very often research that is done, whether in academic settings or as part of projects, ends up filed away and the practitioners do not get a chance to apply that information. So we need to be data and evidence driven, but we also need to be culturally and contextually appropriate. Again, whether it's programs or it is actual interventions. And that is now where it gets back down to meeting men where they are is also about ensuring that you, the provider, are able to be in that space where you're not judgmental and your biases are not interfering with the process. So there's personal work that we as providers have to do also to unpack some of our own baggage if we are to be able to meet men where they are and initiate the behavior change interventions that we wish to do. Cognitive behavior therapy talks about, you know, understanding the thoughts, understanding the feelings, and the link with the actions. So the different levels of intervention that both the research and the actual face-to-face intervention need to touch on. And we'll be touching on some of those in the next webinar.
Thank you very much. Mr. Benjamin, do you want to also touch on this? Where are men now and how do we meet them where they are?
I think Dr. Peter spoke about it at length, but I also think that because of societal influences, because of how we were cultured, I think we are unwilling as a society to meet men where they are now, because we see men in a particular light, we see men in a particular way. And in order for us to do that, I think we have to really go back to the beginning and begin to culture our children differently. And also we need to really change our paradigm, our thought pattern, our processes, our understanding of what man is or what man should become. And I think once we understand those factors, we're going to start to see a move. But I think it's an individual and a societal responsibility in order to see men where they are, see them for who they are, not for what we want them to become or what we want them to be. Thank you.
Okay, thank you very much. One of our presenters posed 3 questions or comments, and I'm going to try to summarize that into one question. The question is it fair to assume the dimension that the dimension that is used is mostly social, and went on to state that help seeking is also about how we communicate the help that is available, or rather readily available. Perhaps we do have to meet men where they are, or perhaps it is that they will respond when they are ready. And unfortunately, we don't yet know how to get to them to that level of readiness for them to reach out. So is it fair to say that the dimension we use to respond to men issues is mostly social, and maybe that in order for us to reach men where they are, we have to also be able to communicate to them what is available and to understand their readiness to reach out?
Well, I'll take a stab at that. I think I touched on this in terms of the policy and program implications about setting up services that are accessible to men. And by accessible, it's not just geographic, but psychologically accessible. Reaching men where they are is understanding where their heads are at, what are their mindsets and beliefs and attitudes, and using that understanding to design messages to connect with them, messages that are not dissonant, that are going to encourage them to become involved. And I think some excellent lessons, as I said, have been learned from the work with HIV about how to get men to change their behavior around certain things like condom use, for example. So that I think that there are models that we can learn from. Now, what the pandemic is going to test with us is how quickly we can scale up the kinds of interventions that were used already for an epidemic, for HIV, etc. How are we going to scale up to understand what are the attitudes and perceptions that people have about risk, about testing, about vaccines, etc., because these are the challenges we're going to be facing as we battle the COVID-19. So I do think we can change, and I would say that we have demonstrated that we can change behavior, including men's behavior. The problem is that this particular pandemic is affecting us on so many levels that that holistic, multi-pronged approach that worked so well with HIV will have to be leveraged and scaled up so significantly, so quickly, that it is really going to be a challenge. But it's not impossible if we understand the science of this process and then the cultural dynamics, and we harness those two to try to achieve our objectives.
Well, thank you very much. Yes, for that. There is a very direct question, and both of you can come in to answer this question. The participant is asking, will you then say that we are growing our boys in a manner that exposes them to more abuse?
If I can take a check on that, yes, I think directly my response is yes. I think what we do to our boys is dangerous. We are setting them up for all manner of societal ills, criminal challenges as they grow older. I think we are not giving the boys the foundation that they really need to grow and develop. Rather, we are putting them in a box and telling them this is what they must do. But when the society in which they grow puts them in a particular way and they respond to that way, then we are upset. For example, when the boy is growing up, we are saying to the boy that you must be in charge, you must be rough, you must be tough, don't take no lash. But at the age of 18, 19, 20, when he marries a girl or finds a girlfriend, and he begins to become violent, we all hold our heads and ball. And then he's the one who's going to be carted away to jail, or he's going to be labeled an abuser. And so for me, we have to be so careful what and how we nurture our boys so that what they become later on. Because we can very well, for example, you grew up in a house with domestic violence. What exactly is that boy supposed to do when he grows older, especially if he has no guidance to move that apple from the tree? And so those are some of, to me, the direct response to that is yes, but I will go further to say, in order for us to change that, we must begin to culture our boys differently. You see, I'm hearing a lot of culture, but we also need the skills people to help us through this as well, because it's not easy.
Could I just add something to that? Because the point that Hanif is making is one that we could unpack at length, but I would just make one point. Unfortunately, what is happening is that we tend to be very black and white, all or none in our thinking about these issues. And so when people talk about, for example, boys being more expressive and sharing their emotions, what we really mean is emotional regulation, being able to identify and know what they're feeling, and then choose how and when to express it in a way that is healthy and not hurtful to themselves, to ourselves or others. And I make that point because if a boy has been taught that he mustn't show any fear or show sadness, and he never learns how to regulate how he expresses it, so he stuffs it all. And of course, you have that explosive process when he becomes aggressive, but you also have that paralytic process when he goes to his healthcare provider who's asking him what is going on. And he feels as if he starts talking, everything will fall apart. So he holds it in. And that is one of the implications we need to understand. So when Hanif mentions skills, it's not about that boys should express their emotions all the time and everywhere, for example, but it is more that they should understand what they're feeling, the implications of it as they mature, they understand that more in a more nuanced way, but also be able to consciously use the skills to express what he needs to express without losing control. And so we really have to work towards that kind of self-analysis, self-regulation, self-expression that is healthy and appropriate and ensures that we get what we need out of life and out of relationships.
Peter, I just wanted to jump back in there. If you allow seconds. You know, this in itself could be a seminar. But what is so important, I want to link what you just said to COVID. And so if you can understand what both you and I just said there, and link that to a person in a home without escape and an inability to link feeling to self and response. And now you can understand the type of explosion that can happen there. I just wanted to throw that in the mix.
We'll have more of that next week. So that's where we'll be going.
Yes, thank you very much for that response. Another question that we have here is men's identity and its relation to sexual rights and gender-based violence, and the intersect between race and ethnicity. How do we handle this?
Well, that is a few dissertations right there. That's a very big question. I think I would answer that by saying, first of all, we need to make sure we're not using our assumptions and our biases about various profiles, that we get the data and do the research to find out how those different dimensions, social dimensions, affect people's attitudes and behaviors. And then we design an intervention that is accessible to the folks based on their own mindset and moves them along a change process. I think one of the behavior change dimensions that we haven't really had time to go into here is that people don't go from 0 to 100. And that is why a clinical analysis of the profile, the attitudes, the beliefs is the starting point, and that is based on an assessment, whether it is research data or an interview. But then you have to look at what is the change process that you want the person to go through, or I should say, more appropriately, what is the change process they want to go through once they understand the costs and benefits. So whether it is race, whether it is religion, identity, sexual orientation, all of those are factors that make up the identity of the person, but they may operate differently with different people at different times in their life, and we cannot make assumptions that one size fits all. So these are important issues to be discussed, but they are complex and they're nuanced, and we have to find ways to coordinate and collaborate our interventions to try to understand them and then effectively intervene.
Thank you very much. We have so many questions that are coming in. Another question that we have here is, how will you suggest equal consideration for the various forms of male sexual diversity can be part of a more comprehensive paradigm shift?
Can you repeat that question? I'm not sure I understood the first part.
How will you suggest equal consideration for the various forms of male sexual diversity to be part of a more comprehensive paradigm shift? So I
How would
think
I
it's
say?
different types of sexual diversity that exists, because when we're looking at, say, the paradigm shift, we're probably looking at a prototype male character and an orientation, and any solution that we're probably looking at is focused on that. But then there are many types of male sexual diversity. How then will that be? How will this influence any shift that we're trying to make?
Another complex question, and I think the challenge is to understand that when we talk about a prototype, we therefore have to look at models, prototypes, not one prototype, but that those prototypes will have different it's like equations with different variables. They have certain things in common and certain things are different. I guess what I'm trying to say is that we should be looking at honesty, authenticity, integrity, commitment, discipline, hard work, blah, blah, those kinds of qualities, which even in and of themselves are value-based. But if we're trying to talk about addressing the needs of individuals who are diverse and have multiple masculinities, then we need to understand what are there common qualities that we all agree on, and if we do, then how do we promote those? How do we facilitate those in relationships and in social systems? It is not to say that individuals' identities with regard to their race or religion or sexual orientation are not important. But I think the significant thing is, where do these core beliefs and values synchronize in a way that we can then engage in conversations, as opposed to seeing people as the enemy and the other? You know, where are the commonalities? Where is the common ground? What can we agree on? And then the conversation can start. But if we start a conversation that my lifestyle is right and yours is wrong, that's only heading into a quarrel. It's not heading into any kind of collaboration. So I think we have to look at what we have in common.
Great, thank you very much for that. We continue to receive questions. I think we have time for just about 2 or so more questions. Another question that we have here is, what type of interventions are currently underway in the region now to support boys and men read their emotional intelligence / self-regulation?
Well, the ones that I know of there are a number of school-based programs that are across the region that are operating, everything from self-awareness, values clarification, to meditation and self-calming strategies that are being used in various schools, as opposed to punishment and detention. And then you have the kinds of programs that are being done in the region supported by various UN entities that are teaching, again, values clarification, but life skills, etc. I think that one of the challenges we face is that some excellent work is being done and there's a lot of interest, but people are not being provided with the tools so that any particular project or country or Ministry of Education will develop a manual and a strategy, and then funding is given to somebody else in another country to develop another manual, another strategy, another project. And we're not getting any synthesis of all of these to see what is really working, what's not working, what are the best practices. And even when that is done, it's not made available to people operating on the ground in the field. So it remains in some folder or in some project document, but it is not disseminated. So I'm a big believer that we're doing good works already, but it's not perfect, and there's a lot more that needs to be done. What we need to do is to find ways to synthesize and integrate and disseminate so that people are not constantly reinventing the wheel and wasting the limited resources we have. And again, the COVID-19 pandemic is going to be another example of that, where the danger is that we'll have a lot of scattershot interventions being done. Everybody's doing something, a lot of busy work, but not necessarily having the impact that we want to have.
Can I just say as well, I'm of a slightly different view. I do not see or have not seen a coordinated, targeted approach to boys in any real sense from whether it is a strategy, a policy position. There are great people doing great things in their own right. But on a national level, a community level, on a Caribbean level, I'm not seeing any dedicated understanding. And so it leads me to the question as to whether or not we understand whether or not it is in fact a challenge that needs addressing. And if so, then why are we not looking at it at a wider level so that we can get the impact beginning, middle, and end, and then some after that? So I think more needs to be done in terms of coordinating at various levels targeted programs, targeted approach for boys in relation to this topic.
Yes, and another question we have here is related to, say, the bias in the healthcare, where it's mentioned that the greater proportion of the healthcare providers or government workforce may be men, and so can this skew in the data in terms of the approach, in terms of data collection, where it may highlight that that because men are probably a greater part of the workforce, they're easily reached by men, and so this is showing that when you look at, say, the new infections and incidents of HIV and COVID-19, that men are the greatest contributor, and they're asking for your thoughts.
I'm not sure I understand the question. I'm sorry, maybe I misunderstood part of it.
Yeah, so it's saying that that the health workforce or the public service is predominantly male, and so can this bias in terms of data data collection that men can where men are the contributor for new cases and so forth, or even the COVID-19 pandemic. Are there any bias there? Can this contribute to any of this?
Dr. Adams, I'm having a problem here. You dropped a while ago. I didn't hear some of it. So let me leave that one for Hanif to respond to, because I didn't hear some of your comments.
I missed what the doctor was saying as well, and I'm not understanding the fullness of the question.
The question is, I think it is seeking to clarify or to understand if men are the greatest proportion of the health workforce, will that account for any bias in terms of data collection and reporting, because men may seem easier, it may seem easier for men to interact and reach men, and therefore women or others may not have been reached, and so the data presented will be skewed towards men.
I'm not sure. Is it Peter's data you all are referring to? Peter, you want to take this?
No, go ahead, Hanif. I'll come in after you.
Because I'm wondering where they got the data that's saying, first of all, men makes up more or most of the healthcare profession. I mean, I could look at Trinidad, and I'm not too sure if that is a statement or a fact that I know of. So I don't want to pronounce on that. But more importantly, while men, based on what they're saying, I don't know that men readily wants to be part of any study or takes time to be part to answer any survey or stuff like that. More so to even have a skewed sense of result. So I'm not sure of the fullness of that statement, and or how to respond to it in relation to say that, you know, more than what I've said already?
There's an assumption in there, if I'm understanding the statement, the question. One of the assumptions made is that men will be more likely to reveal information to men. And that I'm also not too sure about, because men, we have found in our work, are more likely to try to impress men, and may open up more to women when it comes to issues of vulnerability, etc. Now, there's no standard way that this works, but I really am not sure whether those dynamics are going to lead to a skew in the responses in any one way. I think there are many factors that will tend to push in various directions, but I'm not seeing this particular dynamic as having that effect in my observation. But that's limited. So.
All right, thank you very much for your response. I'm going to take just one final question, and then we're going to conclude. Remember that this is a two-part series of questions that may not have gotten answered today. We will appreciate if you will also participate next week, and you can also field these questions. The question is that that there is a challenge for civil society to develop programs for boys because the funders are still very focused on women and girls. This is important, but equally important for us to focus on men and boys. And I guess this is not a question, but a statement highlighting the challenges of civil society to get funding for programs for boys, because there's still a focus on empowering women, the rights of the women and the girls. Any thoughts there?
Well, I would just share one thought on that. That is another multifaceted question. There's a lot of competition for the scarce resources, and that is going to increase. And I think, therefore, those of us who are thinking strategically and understand human behavior, the psychology of people's behavior, need to make the case that this is not about work with boys, for boys, and only for boys. We need to really shift our focus to working on how boys and girls, men and women can relate to each other. And I think that now is the time for more support and creative initiatives that help boys to understand themselves not as a different kind of creature, but as someone who lives in a society and in relationships with other boys and with girls. And therefore, our interventions need to perhaps be a little more conceptually focused on the dynamics within and between and among the genders. And we need to do more work on that. I think that if we did, then our young people, when they go into adolescence, despite all the natural temperamental changes and hormonal changes, would have already initiated healthy relationships, again, among and between the genders, that could then evolve into the kinds of platonic, romantic, productive relationships that are needed. So I really think we need to do more work with boys and girls together. And in that context, boys will learn about themselves, but they will learn about themselves as part of a social structure and not as a separate entity, which I think leads to some of the problems we have.
Thank you very much for your response. We're running out of time, so I want to thank both of you, Dr. Wheeler and Mr. Benjamin, for two very excellent presentations this morning, and also the response to these questions. We have many questions coming in, and they're still coming in. So I'll remind you again that next webinar, the second part of this, will also focus on men's health, gender-based violence, and COVID-19. I'll also like to thank also the Pan American Health Organization for their collaboration in these webinars that we're having. Also, we'd like to thank the participants who have taken their time out to participate in these webinars. As a reminder, please complete the post-webinar evaluation that will be sent to you, and you can also download your certificate of participation in the email received. I invite you to continue to follow us at PanCap using our various social media platforms. where you can access HIV and COVID-19 resources on our website, and also on the various social media platforms that we have on Facebook, Instagram, and on YouTube. So thank you very much, everyone. Do have a great day.